Today we're talking about ART, which is the atraumatic restorative treatment, or sometimes called atraumatic restorative technique. As the name suggests, it is atraumatic, and that's one of the positive elements of this approach to restorative treatment. Atraumatic restorative technique was developed in Africa in the early 1980s because dental schools or dental services had no access to electricity and therefore rotating instruments, instruments for mixing materials, instruments for cutting teeth. And so a very smart person by the name of Franken looked at this problem and decided that potentially there was a way to restore teeth that had cavitated or were cavitating without the need to use handpieces or modern equipment. The technique at the time was developed and primarily thought about as a technique for resource poor settings or poor countries. But over time, dental researchers and clinicians have thought about this a little bit, and with our better knowledge about the biological or pathophysiological aspects of dental caries, we've started to think maybe this is a technique that we could apply even in a modern society, even in a dental clinic which is fully equipped with all of those things, because it's atraumatic and it minimises tooth loss in cavity preparation, and therefore it fits very nicely with minimal intervention dentistry principles. So if we think about why we restore teeth, why do we place fillings in teeth? You've probably got some ideas yourself that you brought to the course about why fillings are placed, but primarily it's to facilitate plaque removal. So if you have a cavity that catches plaque and a patient or a person can't clean that effectively, placing the restoration in that cavity effectively brings the plaque biofilm to the surface where the patient can actually clean it effectively. So when someone asks me what is the primary reason for placing dental restorations in cavities, I would say it's to allow the patient to effectively remove the plaque biofilm from their teeth. It also, if it's placed well, will halt the caries process, and it will do that because it will eliminate the plaque biofilm from the cavity. Some of the other reasons people will put forward for restoring teeth are to encourage the remineralization of caries dentine, particularly if you're using fluoride-releasing dental materials. You will see inside the cavity the remineralization of the dentinal structure. Other people suggest that cavities replace the function of the tooth, and if it's placed in an area which is immediately obvious to other people, it also restores to some degree the aesthetics of the person's tooth. There's lots of reasons for placing a restoration, but primarily it's to arrest the caries process by making the teeth much easier to clean. When we think about how we restore teeth or place restorations, basically there's two stages. There's the removal of carious or destroyed tooth structure that we're not able to remineralize. It's not strong enough to stay in place, and if we do leave it in place, it will undermine the integrity of the restoration, or it will allow the carious process to continue. The second stage, once we've done that, once we've prepared the tooth, is to place a material or apply a material that replaces the lost tooth structure, produces a seal against bacterial invasion, because of course we don't want the plaque biofilm to be able to get back into that site, encourages, as we've mentioned before, remineralization. We need to have a material that is strong enough, particularly if it's placed on the biting surfaces or occlusal surfaces of teeth, that's strong enough to last over time, to maintain function. And of course there's always the question of aesthetics. Will it look better than it did when it was cavitated? Aesthetics, as I say, are more important towards the front of the mouth, but increasingly people now are demanding higher and higher levels of aesthetic quality, even in the most posterior teeth. So we do need to think about those sorts of things. Now, traditionally, in the olden days, and you might have heard of this guy, G.V. Black, he's the grandfather of dentistry. He was the person who wrote the first textbook about how to restore teeth. And when he was writing, there was only really one restorative dental material, and that was dental amalgam. And that dental amalgam relied on a geometrical shape of a cavity in order to be retained. It wasn't an adhesive restoration that stuck to the tooth surface, so it actually required a mechanical lock to keep it in place. And as a result, the design of the cavity had to be geometrically very strict. It had to have straight walls, floors that were flat, very sharp angles in order to retain the amalgam, and undercut so that the amalgam wouldn't be pulled out of the cavity. So you can see here in this diagram, this is the original carious or cavitated lesion, and the grey area here is the amount of tooth around that needed to be removed. This is sound tooth structure that needed to be removed in order to retain the restorative material. This type of cavity preparation actually weakened the tooth, made it significantly weaker. So over time, the tooth itself would fail and the restoration would need to be replaced. And so when we look at the zones of the carious lesion, so we understand now that a carious lesion or a dentinal carious lesion has various zones, and within those zones there's varying degrees of mineralization. In G.V. Black's design, all of the zones, the demineralized enamel, the area of bacterial invasion, the so-called infected zone, as well as the affected zone, all was removed in the cavity preparation process. And you can see here, this is the pulp here is the lesion. In these cases, there was a great deal of destruction, and the pulp, or the cavity preparation itself, came very close to the pulp. So this was quite a destructive process. We now understand much better the pathophysiology of dental caries, and we understand that in a lesion like the one I've just shown you, there are varying areas, different areas of destruction of the dentine and different areas of mineralization. The outer infected area needs to be excised or removed during the cavity preparation process, but the inner affected or so-called affected dentine can be retained because we can actually remineralize that and keep it in place, so that we're actually keeping more of the tooth structure in place than perhaps we would have in the past. That means we're weakening the tooth less, and it also means we're approaching, we're not getting as close to the pulp, so there's less chance of insulting the pulp and getting inflammation of that tissue. So, as I've said or outlined before, the traditional approach was not ideal because it actually, although it halted the caries process for a period of time, it actually made the tooth weaker. The restoration would eventually fail and then need to be replaced. And each time it was replaced, the dentist or the dental practitioner would inevitably remove more of the tooth structure. So over time, the tooth itself would fail because of this process of repeat restoration. We have a better understanding of the biology of caries now, and we've applied that to the principles of cavity preparation. So we now think about cavity cleaning rather than cavity preparation or cavity cutting. So the objectives of cavity cleaning are to obtain access to the necrotic dentine and then to remove any of the soft infected dentine and carious enamel. We're no longer governed by geometrical shapes that G.V. Black was. In fact, the anatomy of our cavity, what it looks like after we've prepared it and before we restore it, is actually determined by the anatomy of the lesion itself rather than a predefined geometric shape. So there is no preconceived cavity design or shape that we're trying to create. Because we have adhesive materials, we're no longer reliant on mechanical retention, so we don't have to cut away sound tooth structure in order to get a geometrical shape to retain our restorative material. So in short, G.V. Black, although he was very helpful 150 years ago, his principles are now redundant, and so we should not be applying those to the tooth restoration or tooth preservation that we use in modern dentistry. So this is more of what we're aiming to achieve. So here again is our dentinal lesion, and you can see here that in the biological cavity preparation approach, we're actually retaining more of the tooth structure because we're retaining this partially demineralized area and transparent zone, the so-called affected zone. So rather than cutting that away as we would have in the past, we're retaining that part of the tooth, remineralizing it, and then placing a restoration to seal this area against bacteria from the oral cavity. So if we look at that diagram against the photograph of the cross-section of the tooth, you can see that what we're actually retaining is the affected dentine, the inner layer of the lesion. We're not cutting it all away. And so we need to be very careful when we are actually removing this, that we know when we are approaching affected dentine, and that's when we stop our tooth removal process. So coming back to the atraumatic restorative treatment or technique, this is a technique that is minimally invasive. It's designed to prevent caries and to stop its further progression. So the full technique actually involves sealing pits and fissures, as well as the minimal removal of carious dentine and the restoration of that with generally a glass ionomer cement. The process involves the removal of soft carious tooth tissue with hand instruments only. So in its pure sense, atraumatic restorative technique does not use rotating hand instruments, the air rotor or the so-called drill. We limit you to using hand instruments, and through that process we're actually less likely to remove too much of the tooth because we're actually feeling more sensitively the tooth tissue as we remove it and as we approach that affected dentine. Whereas with a handpiece, particularly a high-speed handpiece, you can continue drilling through the tooth with very little sensitivity. You won't be able to determine the change from affected dentine into sound dentine, for example. So it's a hand instrument process only. And the question is, why only use hand instruments? If you've got an air rotor sitting next to the chair, why would you bother? Why wouldn't you use that? Well, because using hand instruments only creates the most ideal cavity shape, that is the most conservative. So it saves most tooth structure, because with a hand instrument you're physically only able to remove unsound or infected dentine. Once you start to get to sound dentine, the hand instruments, you can't remove any more of the tooth surface. Whereas with a high-speed handpiece, for example, or even with a low-speed handpiece, you can continue to remove tooth structure for as long as you want. So with this tactile sense you get from just using hand instruments, it means that you're more conservative in the amount of tooth that you remove. It also means you don't damage surfaces adjacent to the lesion, right? So with a handpiece you can actually sort of drill off to the side and remove sound tooth tissue. It's very easy to do that. So it's very conservative in its outcome. Now, let's look at what equipment is required for this technique. So whether you're in the field without electricity, running water or machinery, or whether you're in a modern dental practice, this is the equipment that you will require. So you can see here a basic kit. We've got some cotton rolls, cotton pellets, Vaseline, some other bits and pieces here, some articulating paper, and then we've got our series of hand instruments. So, of course, we would always have the mouth mirror, and that's used for viewing tooth surfaces, but also reflecting light. So, particularly if you're in the field, it's very important that you're able to reflect light into the mouth, and of course it can be used for soft tissue retraction. Cotton rolls are generally described in the literature around art as the technique for isolating the tooth. And that's again because of the lack of equipment, but you could always use rubber dam isolation for the art technique if you wanted to. However, because the art technique primarily uses glass ionomer cement and is primarily done in a situation where you're not able to use handpieces or local anaesthetic, for example, the cotton roll is usually adequate for the art technique. We also require some probes because we want to be able to feel the surface of the tooth. You can decide which probe you use to determine whether or not the caries is soft or is hard once we've achieved that hard or affected dentine. Be very careful though that you gently scrape. So if you're going to use a sickle probe as opposed to a periodontal probe, make sure that you're gentle in the way that you use that probe. And you should never use the probe to press into pits or fissures, as you can actually cause cavitation. And what we're generally trying to achieve in dentistry is stopping cavitation from occurring. So just be careful with the way you use probes. And lastly, never use a probe on the floor of very deep cavities, because sitting underneath that could just be the pulp waiting. So if you apply pressure with the probe, you could actually fall into the pulp. We need tweezers for assisting with moving things around the mouth. And these are the really important instruments, the spoon excavators, because these are the instruments we're going to use to remove the softened dentine. Okay, so generally you would use a large, a medium and a small. A small and a medium is probably adequate, but if you've got all three, that's particularly useful. The different sizes are useful because the sizes of the lesion will vary. Another really useful instrument is the dental hatchet, and as the name suggests, it has a very sharp sort of wedge-shaped edge. This is like a chisel, and it's used to knock off unsupported enamel. I'll show you some pictures of this in a moment. It's quite a sturdy instrument, and you can use a little bit of pressure to push against unsupported enamel to break it away so that we can actually access the cavity. Cotton wool pellets are very useful, particularly if you don't have a triplex syringe with water or air. They can be used for washing the cavity, so a soaked cotton pellet can be used on the end of the tweezers to actually wash out the cavity, and then dry cotton pellets can be used to dry the inside of the cavity after you've washed it. And remember, with GIC, we don't need a super dry cavity. Okay, so these are quite adequate in the absence of compressed air. We then need something like a ball burnisher or a flat plastic instrument to help us to place the restoration into the cavity and to push it down and also to shape it after it's been placed in there. So there's probably a variety of instruments that you could use, a ball or football shaped burnisher, flat plastic, etc. So have a couple of those in your kit as well. One of the interesting things about the art technique is it's actually quite cheap because it doesn't require expensive equipment. Okay, so if you're working in resource poor settings, this is one of the approaches that you should really consider taking, because all of those instruments I showed you do cost money, but they're not as expensive as rotating instruments and other mechanical instruments. In outreach situations, so if you're outside the clinic without electricity, you will actually have to have a self-curing glass ionomer cement. And there are products available in the market where you get a powder and a liquid, and you can physically mix that together on a paper pad with a flat plastic instrument or a spatula. The important thing to remember is that most studies that have been done and published in the scientific literature all use glass ionomer cement. So evidence around using resin composites or other materials in this approach is not abundant. So I guess what I'm saying here is the recommendation is to use glass ionomer cement if you are using the ART approach. Another piece of equipment you might use, depending on where the cavity is on the tooth, is matrix bands or wedges. We won't talk too much about that at this stage, but just be aware that this could be something you would require if the cavity is on a proximal, mesial or distal surface of the tooth rather than the occlusal. The materials, as I've said, are generally glass ionomer cement. These are a couple of, or a few glass ionomer cement products that are available on the market. Chemflex or Chemfill. Fuji make a range of GICs. Some of them are self-curing, others require light curing. So again, it depends on the setting that you're working in. So the glass ionomer cement self-cure, as I said before, if you need to use that, is supplied as a powder and a liquid. There is encapsulated forms as well, but you will require a powered a mixer to actually mix those products. So again, the setting that you're working will determine which products you're using. Glass ionomer cement, we'll learn more about this later, but just a few important fun facts about GIC is it is water-based, and there is water forms the reaction medium within the product, and therefore it's important that we avoid desiccation. So we don't want it to be too dry, and we also need to balance the water content during the reaction process within the product itself. So there's an initial setting where the GIC will set in phase 1 quite quickly, and then over 24 to 48 hours it will continue to set. And it's important that during the initial process that we protect the restoration from moisture from the mouth. So in the field you might want to use petroleum jelly to place across the tooth and maybe have the patient bite on a cotton roll for as long as they possibly can. In a clinical situation, we might place a bonding agent over the top of the GIC just to protect it and to maintain that moisture content whilst the reaction is occurring. The other good thing about GICs is they will contain commonly glasses which have fluoride content in them, and so that fluoride content will assist in remineralization of the tooth surface that the glass ionomer cement is in contact with. So if we leave affected dentine, which is demineralized, as well as physically protecting that dentine from the plaque biofilm, the GIC material is also releasing fluoride, which is remineralizing the dentine. So GICs again are the recommended product because they have this additional fluoride release. The fluoride doesn't affect any of the other properties of the restorative material and continues to be released over time, and there are some fluorides that you can actually recharge them with fluoride. Fluoride is released from most products in a predictable way. Initially there's a huge burst of up to a week where you get significant release of the fluoride from the glass ionomer cement, and then there's a slow decrease over time. The amount of fluoride that is found in a patient's saliva in studies will increase, of course, with the number of restorations that are placed. That just makes sense. And there is a significant body of evidence that those fluoride-containing restorative materials reduce tooth surface carious lesions in adjacent tooth surfaces as well. So GIC with the fluoro content is particularly important, not just for the tooth that's being restored, but for the whole mouth in terms of prevention or reverse of lesions. And of course we might want, if we're working in the field, the smear of petroleum jelly as a lubricant. We can use it if we are using the so-called thumb technique to place the restoration. And also it will protect the GIC to a certain degree after we've placed it whilst the setting continues. But if we're in a clinic where we have access to a bonding agent, for example, it's preferable to use the bonding agent. So how do we select cases for the art technique? Art applications are the following: a cavity involving dentine. But remember, we can also use art to seal teeth. Okay, so we will actually seal the adjacent sound tooth structure, pits and fissures, as well as filling the cavity itself. The cavity has to actually also be accessible with hand instruments. So we need to be able to place our hand instruments, and we need to be able to see into the cavity. The other good thing about the art technique is that local anaesthetic is usually not used, and this is actually one of the indications in which you might use it, even in a modern clinic setting, is if it's not possible to use local anaesthetic for some reason, but you really do want to arrest or stop the progression of a large carious lesion in a tooth, then that's a really good indication for using the art technique. Now, as I have mentioned that GIC actually likes a little bit of moisture, but not too much. So we're not doing underwater or subaqua dentistry here. So there needs to be isolation for saliva control, but it also helps you to be able to see into the cavity. And a tiny bit of moisture is desirable, but too much will actually interfere with the performance of the glass on a cement. It will fail. Okay, so use cotton rolls. If you have suction, so if you're in a clinical situation, you can use suction. If you're not in a clinical situation, you will need to change the cotton rolls regularly, and fortunately they're quite cheap. So let's have a look at the technique now. So the first thing we need to do is to isolate the operating area. And so you can see two cotton rolls used on both the buccal and the lingual side of the tooth. And they can be held in place with your non-dominant hand, or if you have a Garmer's clamps, they can be applied for lower teeth with the Garmer's clamps. This is the tooth that has the carious or the cavitated lesion, which is to be restored. So the first thing the operator will do is to clean the surface of the tooth, particularly if there's debris or plaque in place, to get a good look at the lesion before the process begins. So you can see here a wet, moistened cotton pellet is being used, and then you can dry the tooth surface with a dry cotton pellet. The next thing that's occurring is access to the dentinal cavity, to the dentinal caries. So you need to widen the entrance into the cavity. So that involves removing the enamel that is lying over the dentine. And now in large cavities that will be relatively easy. In fact, it probably will have been done for you because the enamel would have collapsed in. With less large cavities, you might find that you actually have to use some effort to break through the enamel into the underlying dentine. The best instrument to use here is the dental hatchet. It's sharp and relatively rigid. And so you use the hatchet against the unsupported enamel. So when I say unsupported enamel, I'm referring to this area, this brown area here in the diagram. So the caries, the dentinal caries here, you can see is actually undermining the overlying enamel. So by placing the hatchet into this space and moving it backwards and forwards, we're actually going to break off the unsupported enamel. And that's okay because the unsupported enamel is unsupported. It needs to be removed, and we need to gain access to the deeper area of the cavity here. So you can see with this backwards and forwards action, there's a widening of the cavity, or widening of the enamel opening to the cavity, and we call this access form. So once the entrance is wide enough so that we can see into the cavity and physically we can get our spoon excavator into the cavity, we should start to remove the softened dentine with the excavator. Okay, using scooping movements or lateral movements backwards and forwards across the lesion. The spoon excavator has two ends to it. They're contra-angled, so they can be used from different angles. So use both ends of that instrument within the lesion. With smaller lesions, you'll need to use the small excavator first. Okay. And then remove any thin overlying enamel. So you may need to sort of move backwards and forwards between the excavation of the softened dentine and then the hatchet to remove the overlying unsupported enamel. Once you've removed all of the softened dentine, leaving the firm discoloured or the affected dentine within the cavity, give it a good clean out. So use a moistened palette if you're in the field, or the triplex syringe if you're in the clinic, and just have a good look into the cavity to ensure that you have removed all or most of the infected dentine, and all that's remaining is affected dentine. Be very cautious though with deep cavities, because we want to avoid a pulp exposure. So it may be in very deep cavities that we remove most of the infected dentine, but that we leave a small amount if it is sitting immediately over the pulp, and we want to avoid pulpal exposure. Clean the cavity and ensure that you're happy with that before you move on to the restorative process. Wash and dry, as I said, and then apply the GIC, the dentine conditioner, or the conditioning agent that comes with the glass ionomer cement that you're using. So condition the dentine. You can wash the conditioner off if that's required with a moistened palette, and then dry with a dry palette, or if you're in the clinic with a triplex syringe. We then move on to the filling of the cavity, and that involves placing the glass ionomer cement under pressure into the cavity. You can see here in this picture that we're using the flat plastic. Looks like a number 6. Some techniques you'll read about, particularly techniques in the field where there's very little equipment, or very young patients, they will use their thumb with the glass ionomer on the thumb to press it into the cavity. The key thing though, regardless of what you use, is to ensure that the material is being pressed into the cavity, and that it is being pressed against the walls and the floor of the cavity so that you get a very good seal. We want to avoid voids within the cavity, and remember, in order for the glass ionomer cement to remineralize, demineralize dentine, it needs to be in contact with it. Okay. Once you've filled the cavity, overfill the cavity, so make, pile on the glass ionomer cement, and then ensure that any pits and fissures that aren't included in the cavity itself are also sealed with the glass ionomer cement. So we're filling the cavity, and then we're sealing also any adjacent pits and fissures. As I said before, you can use conventional dental hand instruments, or you can use the so-called press finger technique, where you will press the material into the cavity with your thumb or finger with a small amount of petroleum jelly to prevent the GIC from sticking to the glove. Okay, press it down firmly and move the index finger sideways so that you're ensuring that you get the pits and fissures sealed as well. Use a damp cotton palette, not saturated, just damp, so dip it in some water and then press it against a dry cotton roll, just to dampen it, to use it to press the material into place. Here's a picture of the so-called press finger technique. Remember, particularly if you're working in a warm situation, that the setting time of the material is not great, so you need to move quickly using hand instruments, to remove any excess material. Once you're happy that you have removed excess material and that you've got everything in place, you need to check the occlusion, that is the bite, to ensure that the filling material is not too high. And you can do that by using this articulating paper, which is a little bit like carbon paper, that you can ask the patient to bite on. Don't worry too much about this at this stage, we'll talk about it again later. And once you're happy, either place Bond or the petroleum jelly to protect the glass on the cement as it sets. And then the restorative procedure is completed. So instruct the patient not to eat anything for at least an hour while that setting is occurring, because you don't want any excessive occlusal pressure on the restoration. And what you should end up with, ideally, is this situation. So here's a tooth that's been restored with this technique. It's been cut down or sectioned down the middle. And you can see the GIC material here is really sealed in, fitting very snugly against the inner surface of the cavity. And you can see it's also replacing the form and function of the tooth occlusally. So this is a well-packed GIC. Now, one word of caution with this particular technique is that most of the success and most of the research that shows that this technique is successful over a period of time, once the restoration has been placed, is concentrated on single surface restorations only. So they're cavities that exist on one surface of the tooth, the occlusal surface, for example, or the buccal or labial surface of a tooth. Once cavities involve multiple surfaces, so the cavity spreads from one surface to involve another surface, the clinical outcomes in terms of the research we have at the moment are less clear. We have very good evidence that single surface restorations, the longevity, how long the restoration lasts, is in some cases as good as an amalgam restoration placed in a conventional way. But if you are going to restore multiple surfaces, so you can see here the occlusal surface and the mesial surface or distal surface of the tooth is involved, it's likely that it won't last as long. Okay, but in terms of your placement technique, you will need to use something like a matrix band in order to press the material against it to give the restoration shape and to avoid overhanging margins. Again, don't worry about matrix bands at the moment. That's something that we'll talk about much later, but this is just for complete information for you. And just to finish off by looking at some of the statistics in relation to the survival, because one of the criticisms of this particular technique is that it's a temporary or short-term measure and doesn't last as long as regular restoration, so they're not as good, and therefore if we have a preference, it should be for conventional restorations. When we look at the research that has been done, we can see that the survival rate over a 3-year period is actually quite good. Okay, so many of the studies, 3 years, we've got 88% survival. Maybe not so flash here, but perhaps it was the dental student that was involved, or perhaps it was the material that led to less success over time. But generally, this level of success is consistent with the longevity of restorations that are placed in a conventional way in a modern dental practice. So some good evidence for the longevity of single surface restorations. When they do fail, it's likely to be as a result of the material that's used, or some studies have found that the experience of the operator makes a difference. So the more experience an operator has with the art technique, the longer the restoration lasts, which sort of makes some sense. When we look at conventional restorative materials, just as a comparison, amalgam, dental amalgam, the silver amalgam, and the resin composite, oops, let's go back, gone too far now. The resin composite material, you can see that the longevity of those is similar to the art technique. And in fact, you can see here when you compare amalgam restorations compared to two different studies that looked at art, we actually see no significant differences when you look at the confidence interval whisker here. There is no statistically significant difference between the art technique and a conventional dental amalgam restoration on single surfaces. What about deciduous teeth? So many of those studies involve permanent teeth. When we look at deciduous teeth, there is some evidence that suggests that the success rate is variable, okay? And again, we need to probably ask ourselves why. One study here at 3 years had very high success, and then another study, they found that less than half of the restorations were still in place after 3 years. But with deciduous teeth, one of the things or primary teeth, these are the so-called baby teeth, you need to ask yourself, how long is that tooth actually going to be in the mouth before it's replaced by the permanent tooth? So in a child patient, particularly an anxious child, or a child with disability or behaviour management issues, 3 years might be all you really need in terms of the longevity of the restoration. So when we look across the literature, there is a large proportion of restorations that could be treated using the art approach, but currently are not being treated in that way. They're being treated in a conventional way that actually results in more tooth destruction. Single surface art restorations were smaller in size than those produced with handpieces. So studies that have compared a similar lesion when it's prepared using the art technique as opposed to when it's prepared using conventional handpieces, they actually found that the dental operator ended up removing more of the tooth structure with the rotary instruments than the hand instruments. And the reasons for that I've already discussed. Another interesting thing is that the art approach in many studies was shown to be more acceptable to patients than the conventional approach of using a local anaesthetic and a handpiece. So again, thinking about our patient acceptance or comfort, that's something that maybe we need to consider as well. So art should be something that you think about in modern dental practice as well as in resource-poor settings, because it's a treatment modality that is minimally invasive and may actually benefit people. So deciding when to use it, of course, is the important thing. And when art does fail, it's because people have tried to use it in situations where it's really not indicated. So if you restrict it to those lesions, single surface lesions, you're more likely to gain success. Knowing how to manage failures as well is also important. So we can see here lost part of the restoration in the central pit here. In this restoration you can see is an upper tooth. In the posterior groove of an upper molar, part of the restoration has been lost as well. So these can this be repaired, or is this an indication that the tooth in the first instance wasn't suitable for an art restoration? Those are the questions that need to be asked when the restoration fails, rather than just redoing it and repeating the same mistakes. But generally, the reasons that we see or assume lead to failure are the incomplete removal of dentinal caries, particularly around the dento-enamel junction, and that's where the bond of the GIC is the most important. So inadequate or incomplete removal of necrotic dentine. Inadequate conditioning, so we don't condition the cavity well, so there's a failure of adhesion of the GIC. It could also be because of inadequate isolation, too much moisture, and therefore a failure of the glass ionomer cement. In the field setting, some of the failures were put down to improper mixing of the glass ionomer, so the powder and the liquid. So if you put too much liquid, not enough powder, for example, you'll get an inferior glass ionomer cement. This is not an issue with the encapsulated systems that we use in our clinics, so it won't be a problem if you're doing this in a clinical setting. And the last reason for failure is the poor insertion of the glass ionomer filling into the cavity, so leaving voids, not filling it adequately, leads to fracture of the material and failure of the restoration. So the first thing to do when you see a failed restoration is to ask yourself why. Why has it failed? What is the reason for the failure? And if you know that, that will stop you from making the same mistakes again, a second time. Commonly we don't ask ourselves why restorations fail, we just replace them and we see them failing again. Okay? But if you apply the procedural steps correctly, then you will reduce the failure rates. And the other thing, also if you do see some fracturing of the restoration, repair is preferred over replacement. So if you can judiciously repair the small amount of restoration that's been lost, that is more desirable than replacement over time, because that leads to more tooth tissue loss. So all of the materials that I've used today in the lecture are from Frencken and colleagues. Dr. Frencken is the guy who actually conceived this technique in the first place, and he has published extensively over time and continues to publish about the applications and the success of the ART technique. Also, if you look at the pink book, the Caryology book, which is the Bible in terms of caries, have a look at chapter 23. There's a nice chapter on the atraumatic restorative technique approach.